Good afternoon, everyone. I am so glad that you're able to join us today. My name is Ann Stevenson. I work at the Broad Institute and Harvard School of Public Health, and I'm part of the Broad Global Health Initiative. We've been doing a series on COVID and trying to feature and talk with different collaborators from the Broad that are facing COVID in their communities. And so today we're turning to Mexico and some longtime Broad collaborators there. And we're going to be talking about metabolic disorders and particularly things like type 2 diabetes. And so just a couple of housekeeping items. We are recording this event, and please submit your questions by the Q&A box at any time. And we'll also try to have about 20 minutes for questions at the end of the talk. And then all of these talks have actually been put up on YouTube and the Broad's Global Health YouTube page. So you can find it there a few days after we record it. So at this point, I'm going to hand it over to my colleague, Ana Maria Olivares, who works at the Stanley Center and the Broad Institute. Thanks, Anna.
Thank you, Anna. I'm very happy to be here on behalf of the Latinx group and joining forces with Broad Global Health Initiative today for today's talk. Just a little bit of a background. The Latinx at Broad subgroup is a group of shades, affinity group at the Broad Institute. The mission of Shades at Broad is to advocate for and support the recruitment, development, and success of ethnic minorities at the Broad. Similar to that, in Latinx at Broad, we seek to build community among Latinx employees and affiliates, promote our rich culture, and also provide education research that is done by Latinx scientists and is also impacting our Latinx communities. I am especially happy to be hosting today's talk, as the topic of discussion really hits close to home. I'm a project manager at the Stanley Center, and I work with the NeuroMex initiative, where we're aiming to advance the neuropsychiatric genetic research in Mexico. This means that we are constantly working with Mexican population, with our team there. We travel and we are in constant communication with them. I'm also originally from Colombia, and like many of my Latinx abroad community, we call a country in Latin America home. So to me, it's very important to be here today. Just a little bit of background of what is the current situation in Latin America right now. Most of the countries right now are experiencing a sharp increase in the cases daily, which it's showing that Latin America has become like the epicenter of the pandemic, especially now that the daily report rates remain really high. And in other countries, as you can see in some of the graphs that I'm showing there, daily rates are increasing, while in other countries it's been dropping. So it's definitely a good moment to talk with our collaborators and just get a little bit of knowledge and understanding of what is happening in one of these countries. In this case, we will be talking with our collaborators in Mexico. So maybe I would like to start with Dr. Carlos. If you could tell us about yourself, what you did prior to the COVID-19 pandemic, and maybe tell us about how your daily activities have been changed due to the current situation.
Thank you, Ana Maria, and thank you for the opportunity for talking to your group. I'm a clinical researcher. I'm the head of the nutrition area of a national institute, the National Institute of Nutrition and Medical Science. My work has been mainly research and seeing patients. I see patients 2 or 3 days in a week. Since the COVID outbreak, my life has changed a lot because we stopped seeing patients. All the research studies has been conducted by phone or keeping contact via email or any other electronic way with the patients. And we have focused mainly to support the structure of the institute. Our institute is now a COVID center, so it has been a huge effort to keep the attention of the COVID patients in the best standard. We have to modify our procedures, our daily lives to help the attention of COVID in Mexico City.
Thank you, Dr. Carlos. And also now to get a little bit more of the perspective from the research side, we are joined by Teresa and Alicia. If each of you can tell us a bit about yourself, what your research entitles, and how this has changed due to the pandemic.
Hello, everyone. Good afternoon. Well, I'm presently head of the Genomic Medicine Research Unit at the National Institute for Medical Science and Nutrition in Mexico City. Our unit is also part of the National University in Mexico, also called UNAM. I studied at the School of Medicine at the UNAM in Mexico City, and then a PhD at Cornell University Medical College in New York City. The Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zubirán is one of the leading national health institutes in Mexico for the treatment of metabolic, immunology, and infectious diseases. Presently, there are more than 40 different observational drug and intervention studies that have been carried out in the Institute. And I will talk about some of the efforts we have been putting together with this opportunity of the Institute being converted to COVID Center. Before the COVID epidemic, our group was focused on the study, the expression and the function of the MC11 transporter, which is the product of the SLC16A11 gene, which is a major determinant of type 2 diabetes in Mexican mestizos. We want to describe the expression of this protein in different human tissues, as well as to characterize the subcellular localization and the function of this transporter in different cell organelles, including mitochondria, peroxisomes, and lipid droplets. We also are interested in studying the intermediate role of lipid traits, such as HDL levels, on type 2D risk in Mexicans. We will talk about later about this high prevalence of chronic metabolic diseases in our population, and how many patients present different, not only comorbidities, but these entities together with type 2D, and then we are interested in defining how these other metabolic disorders modulate the risk for type 2D. Since the outbreak, we saw this huge opportunity to study previously cohorts that had been studied in close collaboration with Dr. Carlos Aguilar group, both population-based cohorts as well as hospital-based cohorts for the study of different type 2D complications. And then we, as we will talk later, we have initiated, recontacted all these groups to study how exposure and signs, symptoms of COVID-19 have been presented in different individuals. If you want to go over, Alicia.
Yeah, sure. Hello, everyone. Well, first of all, thanks to all the organizers for inviting me. Well, I majored as a biologist, and here in Mexico, I work at the National Institute of Nutrition as part of Teresa Tusié-Luna's group. And I'm currently interested in genetics of type 2 diabetes and gestational diabetes as a model of fetal programming and susceptibility to other metabolic diseases. I have experience analyzing genome-wide data generated either through microarrays or whole exome sequencing. And well, actually, by the time the pandemic started, I was at the Broad working along with Josep Mercader and in Jose Flores' group. And we were performing a GWAS meta-analysis for type 2 diabetes in Latino populations. So in my case, after the broad lockdown, I came back to Mexico, but I'm happy to say that I have been able to keep working with my analysis. You know, all these apps like Slab and this Zoom have allowed me to be in close contact with colleagues. And also I am very thankful with all researchers that have kindly invited me to join their virtual meetings. But yes, as Teresa Tusié just said, it was like almost compulsory to urgently plan how to recover the health status of those patients that we have previously recruited for other research protocols here in Mexico, and for whom we have like a very extensive characterization, not only genetically, but also clinically and metabolically. And also, as Carlos Aguilar said, this kind of research at pandemic times is very hard and challenging, but I think that also super educational. You know, under normal conditions, we easily get in touch with the patients. I know by setting maybe a face-to-face appointment at the hospital, and probably you would want like to take any biological sample, but now during COVID times, that's just impossible. So all what we have is this limited remote contact with them. But I think that somehow the pandemic has like pushed us to make a step forward and like to learn and develop new tools that maybe otherwise could take us a very long time to implement. So yep, that's it. I think that we have been like resilient enough, and in spite of everything, things are moving forward.
Well, thank you all for your introductions, and that's good to know about how, you know, we're seeing the positive side of the situation, where how we can be resilient to this situation. Maybe we can start with Dr. Carlos. I know you as a clinician are seeing a lot of things. If you can tell us a little bit of what you're seeing in Mexico City and what is the entire experience like.
Could you put the slides, please? The outbreak started in Mexico City in the last week of February. Could you move the presentation, please? The isolation procedures start at the middle of March. And since then, the number of cases has grown steadily. Still, the number of cases is enhancing. For example, yesterday we have the highest number of new cases reported by day. The strategy was the social distancing during March and April. And during May, June, and July, these strategies has been softened, and gradually people has come out to the streets, and some of the jobs has been regained the usual activity. So this has increased the number of new cases and also the lethality of the disease. In the next slide, please. This is the current state of the COVID-19 epidemic. As you see in the map, the distribution of the new cases has been irregular along the country. The outbreak starts in the center in Mexico City, and also in the northern border in Tijuana and Sonora. And in the next few weeks, the outbreak moved to the south, especially in Tabasco and Veracruz, in which now is the area in which more number of cases has been reported. Until today, 268,000 cases has been confirmed, and 32,000 deaths has occurred in our population. 80% are managed at home, but also nearly 20% has need the hospitalization. In the lower graph, you can see the age distribution of the cases, the total cases and also in the stronger red is the age distribution of the cases that has been admitted to the hospitals. As you can see, the curve has shifted to the right based on the characteristics of the population. It's well known that several conditions has increased the severity of the disease, ending in hospital management. In Mexico, these conditions are very common. In the middle size of the graph, and you can see the contribution of each one of these risk factors. Obesity, diabetes, and smoking are the major drivers of the in-hospital cases. In the next slide, please. The federal government was well prepared for the outbreak. They start talking about that since January, and a full strategy was implemented. That is a little bit different what has happened in other countries. The main goal was to increase the number of hospitals and ICU beds for COVID patients. And this implied that almost 300 hospitals changed completely the function, including the hospital in which I work, moving from highly specialized medicine to completely devoted to treat COVID-19 patients. And as new cases has reached different regions, the hospitals are selected and change their function to treat only COVID patients. And as a secondary goal, it was selected to decrease mobility of the population to stop the dissemination of the outbreak. However, this has not been completely implemented because of the social issues of stopping labor in our population. Nearly 50% do not have established work, so they have to get out of home and look for the income every day. In the last few weeks, more emphasis has put in hand washing, cough and sneeze etiquette, and also to reach social distancing without staying necessarily at home. And also from June to today, the face mask has become a usual standard for any job, or even in open places, many people are using face masks. In the next one, please. The number of letalities has keep constantly reaching a bigger number. The curve for Mexico is the red one, just in the middle. We have, comparing to other countries, a very high lethality rate, just because the comorbidities that are common in Mexico, based on our epidemiology picture, we are seeing patients with type 2 diabetes at age 30 or 40 with severe cases of COVID-19 that are not seen in other countries. We have identified this as a research opportunity to develop new estimation tools that these variables are not considered in the tools that are published in Caucasians or in the Chinese population. So we have to develop our own risk calculations based on this different epidemiology. Thank you, Ana Maria, for the question.
Thank you, Dr. Carlos, for that information. Maybe if we discuss a little bit more, we can hear from Alicia's perspective. Is there anything unique from Mexico or the Latin American populations that you think makes them more predisposed to the symptoms of COVID-19?
What I can say is that, well, the short story is that Mexican population was formed from the mix of two main ancestries, the European and the Native American. So on average, the Mexican genome is like 50% European and 50% Native American. But those proportions rely on the sampling region, where the people come from. So it turns out that people from the north of the country have a higher European ancestry. Meanwhile, people from the South have a higher Native American ancestry. And what is more, Native founder populations were not the same in all regions of the country. But however, what it is well known is that Native American ancestry positively correlates with a higher prevalence of metabolic diseases. And this includes diabetes and obesity. And although this may be related, to poor lifestyle or dietary patterns, maybe disparities in healthcare access, genetics also play a very important role. So today there are few US and Latinos, but at least those performed for diabetes, they have resulted in the identification of novel variants, and actually have proven that people with a high Native American ancestry harbor a strong genetic contribution for diabetes. And unfortunately, it happens that diabetes has been consistently reported as a major risk factor for both getting infected with SARS-CoV-2, but also having adverse outcomes. So one may easily think that the high prevalence of diabetes and other metabolic diseases among Mexican population, and specifically among those that have a high Native American ancestry, will indeed increase the risk to develop COVID-19 or show a severe form of the disease. So can we see this blue map, please? So this is a map representing the percentage of Mexican population that self-identifies as indigenous. So the darker, the more indigenous individuals. And so far, most of them, can you click, please, to show the next? Yeah, thank you. And well, so far, most of them have been actually impacted by COVID-19. But I would like to draw your attention to the prevalence of diabetes among Mexican indigenous and non-indigenous COVID cases. So according to the National Health Survey in 2018, the national prevalence of diabetes was 10%. This is only considering medical diagnosis. So this number is equal to the prevalence of diabetes among non-indigenous COVID cases who were specifically treated as outpatients. This is shown as in yellow. And probably they were treated as outpatients because they developed a mild form of the disease. However, the prevalence increased to 14% among indigenous cases. They were also treated as outpatients. And finally, in white, you can see that that consistent with several worldwide reports, diabetes is more prevalent among COVID cases who had to be hospitalized. But again, it is higher among indigenous people. So these are national-based results until July the 2nd. And unfortunately, there is no available data about potential confounders, like, for example, diabetes treatment previous to the COVID infection, or how many of these patients had uncontrolled diabetes. So we expect to have such detailed information for the subset of patients that are being recontacted or de novo recruited at the National Institute of Nutrition. So we don't know if we will find like something private to Mexican population, but definitely previous studies in Latinos, specifically for diabetes, have been very informative of new pathways and actually have advanced the field of metabolic diseases. So we will have to wait and see.
Thank you for that information. Maybe if we develop that idea a little bit further, now that we're talking about difference between like indigenous populations and non-indigenous populations, what kind of difference in health disparities have you experienced or seen within the context of Mexico? Maybe Dr. Carlos or whoever wants to chip on that.
Yes, the cultural issues has played also a role in the outbreak. For example, in some areas, in rural areas, the people are not believing about the outbreak, and also they are not accepting the participation of the local governments. So the teams that are moving to the indigenous groups or even semi-rural areas, they are rejected from the communities, and some accidents have suffered the medical teams when they are trying to reach these people. Regrettably, many of these cases, people living in the cities, when they go back to celebrate Mother's Day or Father's Day, they transmit the disease to their relatives, and now is perhaps one of the major concerns of the outbreak, because the number of cases in indigenous communities and in semi-rural spaces are reaching very high. We have saw several families, complete families that has suffered fatalities because they have a special susceptibility for having severe forms of COVID, and also they have limited access to the proper care. They have to move to the main cities to have access to the hospitals. Thank you, Ana Maria.
Thank you. I also just want to remind our audience to feel free to submit any questions for our panelists at any time, and we will dedicate some time at the end of talk for your questions. Now that we have discussed a little bit about the situation, the current situation, maybe we can get more information from Teresa about the research initiatives that you are doing for COVID-19.
Yes, thank you. Well, if you allow me just to add few things to the previous subject. As Carlos mentioned, Mexican economy has a large informal employment and subemployment sector, in which close to 50% of the people is self-employed and runs a tiny informal business. These people have no savings, and the government health system is not sufficient to provide services for all of them. This situation makes almost impossible to undertake and implement enforced effective social isolation measurements for weeks or months. So on top of our putative increased susceptibility due to the chronic diseases, or even the other aspect I want to mention is the role of previous infection diseases that could occur in Mexican population. We still have a large prevalence of both viral and parasite infections along many regions of Mexico, including malaria, tuberculosis, Zika, HIV, for example. So it is a unique setting where not only biological factors are playing, but also social and totally related with these non-chronic but prevalent infectious diseases as well. And regarding to the participation in international COVID-19 initiatives, as I should mention that we have a long-standing collaboration with Dr. Aguilar group to identify susceptibility genes for dyslipidemias, type 2 diabetes, and its chronic complications. But from March to this year, to now, we have engaged in a large effort to contact individuals from our previous cohorts, both population-based and hospital-based cohorts, including in total around 10,000 subjects, from which we have extensive socio-demographic, clinical, and laboratory data. We are currently collecting information regarding exposure to SARS-CoV-2, manifestations, comorbidities, socio-demographic factors, and we are inviting these individuals to obtain a blood sample for serological studies. We are going to talk about a little bit later of why we are so interested in not only testing immunological response to SARS-CoV-2, but other putative infections in Mexicans. In addition, well, in total, we have about 4,000 subjects with extensive genotyping coming from the Sigma initiative and exome sequencing. And from those subjects with a large genotyping data, we have around 2,000 with true metabolomic data as well. So we got financial support from the CONACYT instance, which is the NIH equivalent for Mexicans, to undertake this recontacting of the previously characterized cohorts. But we also initiated 2 new cohorts, hospital-based COVID-affected patients, both hospitalized and outpatients from our institute and from other large hospital that attends the employments from the oil governmental company called Pemex. So today we have like around 3,000, in total 2,000 cases already from this collected during the outbreak. And we are also initiating with the recruitment of the health personnel working at the Institute during the period of March through December of this year, which includes doctors, nurses, laboratory technicians, and other support personnel, to be able to cover all this situation of not only highly exposed individuals like doctor, nurses, but also the outpatients which are not critically ill, as well as the hospitalized ones, which could be included as well. As a result of that, we have reached putative collaborations with Dr. Jim Wilson at the University of Edinburgh. We have expressed our interest to participate in the Corona Genes Initiative by incorporating our new building cohorts. And also through Andres Moreno, who is a researcher in another big research institute in Mexico, we are we put together a grant for the NIH UK COVID-19 initiative, precisely to be able, through a Luminex type platform, be able to analyze different immunological responses to not only viruses, but bacterials and parasites, and being able to analyze how this could impact COVID susceptibility, not only for disease, but severity, for example.
Thank you. Just if you know some information about what is the testing situation like in Mexico? Are there any difference in the different places where you're getting these tests done? People participating in the projects?
I can answer this question. The testing has been limited to the symptomatic cases. You can go to a private lab in which you can have the test. However, these results are handled in a different way. The results are not incorporated in the national database. Many hospitals are opening testing places, but they are only limited to symptomatic cases. In some areas, like Mexico City, has started a scrutiny of open population and also or reaching contacts of suspected cases, but this is not a regular practice along the country.
And I think the government made a crucial decision from the health authorities from the beginning of the pandemic. The decision to avoid performing massive COVID-19 testing. Up to date, less than 500,000 tests have been performed nationwide. And this not only resulted in apparent high lethality rate in Mexico, which now is about 12%, but also has resulted in the inability to identify and isolate efficiently the COVID-19 positive cases. As Carlos mentioned before, we have 6,000 new cases, infected new cases daily, in addition to about 1,000 deaths per day. Moreover, starting the beginning of this month, as Carlos also mentioned, social isolation policies relax in many states. Differentially, but because governmental authorities make their own decisions. But for example, in Mexico City, which has 20 million inhabitants, including the surrounding areas, which represents 70% of the Mexican population, the number of cases keep rising, and the other alarming data is that from all the infected cases, about 20% are from health professionals, which will impact broadly in the next few weeks.
Yeah, well, probably I can share with you some data from a follow-up, well, actually the follow-up that we are performing, that we are performing on patients from the Institute that are not infected with COVID-19, but we are gathering information about their symptoms, for example. And this shows that until the second week of June, 80% of them were still at lockdown. And they said that they started it at mid or late April. So of course, there might be any bias on this, because we already know that people who are very collaborative with research protocols used to be more committed with their health. And well, probably because they had already been diagnosed. But in our case, 30% of these participants are diabetic. So probably that's the reason they are at lockdown. But yeah, as we have said, this is just one side of the coin. Mexico is a country of huge disparities. So yes, economically disadvantaged people have had to continue their normal activities, and most of them almost with no protection.
I think that's the situation, sadly, in many countries. Maybe out of all of these, if each of you can tell us what you think we can like be lessons learned from how we have handled the pandemic from the clinical side, and what kind of research we can contribute, and how different institutions or the government can contribute to make this situation better. If you can give us an insight of what you think we can learn, and in case this happens again, what can we do better?
We can learn several lessons from this effort. First is that we have to improve the general health of the population. Obesity, diabetes should be treated in a more efficient way, because this condition exacerbates the impact of any infectious disease. We have seen this before with tuberculosis, with influenza, and in the future, we are sure that we will have additional outbreaks, and COVID will stand for a long time. So we have to improve the primary care of our population. Something that the federal government has done very well is to try to build teams. For example, many hospitals has improved the quality of care of COVID patients in a very short period of time. And also the federal government had an open data policy that allows many groups to do research and to have individual insights of the results, and to try to do artificial intelligence and complex modeling for the to learn from the different regions of the country. What it should be done in a better way is to increase testing, not for the general population, but for cases that are contacts of suspicious cases, in order to isolate better the transmission chain. This is an area that we have to invest more money, and also we should learn how to have COVID centers that also provide care for all the other conditions. We are facing now the deterioration of the health of patients with diabetes or many other chronic diseases that has stopped having the proper care because of the COVID outbreak. For example, patients with type 2 diabetes, they are coming in with severe hyperglycemia because they do not adjust the medication as regularly done. And also some medications has went with limited numbers in the pharmacies, so they have stopped regular medications. Thank you, Ana Maria.
Teresa, if you want to say something about things that we can do better in the research side.
Yes. Well, I think the idea is that we can convince the authorities as well as the society to invest in a real effective healthcare system. As mentioned by Carlos, few sector of the population has access to the private medicine facilities through insurance, for example. So most of the burden is on the governmental institutions that take care of this. So having a strong health system and articulated with ongoing efforts from the National Institute of Public Health for these population surveys will build a great effort to be able to participate in different international as well as local initiatives for trying to identify how these chronic diseases, infection diseases, and social factors play into the COVID-19 epidemic. Although I'm positive about our efforts within the health within the health system, I think government should change priorities in terms of building a strong infrastructure for research that could respond easily and rapidly to these kind of outbreaks, which this one, for example, will last for months or even years at the rate we have been handling things like right here. So on the other hand, I think the social environment is really grim in terms of that the economic impact of the epidemic is huge. So it is likely that we experience a long and painful economy recovery. Presently, there are like 2 million unemployed people just from March to May. That before the pandemic, they work in small or medium companies, but now they are unemployed. So it's going to be very difficult for the government and for the society to convince of the need, I think, as a priority to invest in health, to invest in strong institutions and biobanks, things like that, for future discoveries that can impact on the health of the population. But I think this outbreak has provided also the opportunity for looking outside Mexico more than ever, no, to put the opportunities in the light of other initiatives and to work together in that direction for this very exciting also opportunity to build and to uncover biological factors implicated in this very devastating disease.
Thank you, Teresa. I think we have some questions from the audience, so we're gonna turn to them. I think, Browen, you have a question.
Hi, yeah, can you hear me?
Yes, we can hear you.
Oh, great, thank you. Thank you for this just amazing insights you've shared. It's been fascinating. I actually have lots of questions, but I'm wondering, we heard a few weeks ago from colleagues in Brazil who were describing the high incidence of COVID-19 in remote Amazonian populations, and though they don't know, what the genetic and other underpinnings of that might be, it just makes me wonder, how better we could understand these factors in indigenous populations. And I'm just wondering if you're able to stratify the populations living in similar communities with similar, lifestyles and healthcare access by those who are more indigenous, let's say genetically, or less indigenous, to learn more about the contributions of these variants and the comorbidities that they, or the diseases that they cause and how they relate to COVID-19. Sorry, that was a long question. Did you get that?
Yeah, maybe I can start. Yeah, well, as I said, definitely the prevalence of these risk diseases are higher among Mexican people with high Native American ancestry. And that happens not only with diabetes, but also with obesity and also these lipidemias. So currently in Mexico, we do not have an exact number of how many diabetes cases we have, like in these indigenous communities. But with this data that I just show you, we can see that actually the prevalence of diabetic people is higher among COVID cases. And so that may probably be also caused by, healthcare access.
I would like to add what Alicia said. The most important factor is access to medical service and the social environment. The comorbidities is a very important issue, but the proper access to health services is even more important than the comorbidities.
Great, thank you.
If I may, I just want to add that coming back to the fact that Mexican mestizos and most populations from Latin America represents an mixed population with, in our case, Mexicans, mostly European and Native American ancestries in similar proportions, but Native American component has large variations along the country. This is very fascinating in terms of population genetics.
Yeah.
For example, how many Native Americans distinct groups are represented in our admixture population today. And from those groups, we know that there are there are few examples, but there are in some instances large differences in the frequency of different alleles, even among different states within Mexico, which reflects not only these different proportions of Native American and European, but the component of the Native American groups. When we have studied that, the frequency of some risk alleles for type 2 or are very different from themselves. So yeah, that represents, and this applies also for Brazil or for other countries in which not only the Native American background is larger, but is certainly different from the Native American groups, which are part of the background in Mexico. So I think this idea of being able to see how Native American ancestry affects not only the known comorbidities associated to higher risk, but to COVID-19 and other diseases susceptibility as well, will be very not only important but interesting in terms of, for example, if AC2 receptor allele frequency for some variants, we have seen that is we have seen huge differences from 0.1 to 0.001% among different states in Mexico, comparing north to south. Just only this piece of information gives you the idea of the complexity, but also the interest that we have in dissecting this putative Native American component as a risk factor for this disease.
And thank you.
Cool.
Another question from our audience. Mari Carmen, if you can unmute yourself and maybe ask your question to our panelists. I'll try and do her question. So the question from her is, can you talk further about the health disparities in Mexico and what is the effect of those health disparities during the pandemic?
Yeah, I'm sorry, I'm just unmute myself. The point is I'm in the lab, so thank you for reading my answers. It was partially answered, but if they can talk further about it, that will be fine. Sorry, I'm in the lab with other people.
Okay, the social issue is a very important part of the government response, and also to the susceptibility of the population for having severe COVID. Also, the people that have social insecurity are the ones that has higher rates of obesity and higher rates of untreated hypertension or untreated diabetes. So these negative components are just in the same individuals. One of the good things of the federal government's response is that now the COVID centers are completely free. So you don't have to pay anything for the medical attention. And also several private hospitals has given beds to help to attend these patients. So the economic part, if you reach a hospital, you will have a proper care that has been standardized all along the country. So these health disparities has been decreased in some way, but the social issue, the long ongoing social disparities has a crucial effect on the prognosis of our population.
Just to complete the question, I'm sorry. I think after this pandemic, I hope the government tried to keep this kind of programs to improve the public health overall, as you mentioned, that we have a lot of comorbidities like obesity, diabetes. So I hope these plans keep going, right? I mean, I hope this is the plan for the government. As you mentioned, we have a high incidence of obesity in Mexico overall.
Yes, I hope so. They have been saying that the next pandemic that we should focus is obesity, but this is a more complex issue. So many voices has raised the intention to participate, but we have to expect.
Thank you.
Thank you. And I guess we are almost running out of time in this talk, but I wanted maybe to end with a hopeful note and ask our panelists, what are your hopes and changes that you want to see in your country after this pandemic?
I will start. I'm sorry for taking the word. What we should learn of this is that giving a good health to the general population is a very good practice to protect against other infectious disease. So we should keep the eye on pressuring the government to give access to all the population to the proper care, especially primary care, and to focus in chronic disease that decrease the susceptibility of our population to new infectious risk. And also the good things that we should keep is the access to the medication. That is the first time that anybody can have treatment in a hospital. That I hope this will prevail in the future. And thank you, Ana Maria, for the invitation, all the team for this opportunity.
Well, I would like to stress also in the importance of metabolic health. I think that we should take this as a very good opportunity to implement ourselves preventive health measures without waiting for anything like this, like the pandemic. And second, I think that we have realized about the importance of medical records. I'm talking thinking in research, but I think that in order to have more detailed prospective information about patients, we should think to improve this biobanks and electronic medical records that in most hospitals we are missing.
Well, I think, as I mentioned, the government has to rethink about priorities. I am very worried about the decision of the Mexican government, for example, to refuse to get international new loans for trying to keep up with these emerging priorities, as we call it. But this pandemic has shown us that it is possible to rethink things and to get more active in terms of social impact. I think most of the changes are expected to be driven from non-governmental organizations. We have a long tradition of this kind of organization in Mexico for children undernourished children, women, indigenous people, etc., which have experience as well an on-site knowledge of the situation in different regions of the country. So I'm very positive and optimistic about the possibility of this being more that these non-governmental institutions take lead role in all the initiatives that we have to direct specific to the needs of different rural or non-rural areas in Mexico, which along with the social and biological factors play very different situations in different regions of the country.
Thank you everyone for your answers. I just want to take the time then to thank our panelists for taking the time out of your busy days and sharing with us your experience and your knowledge. Also the audience for joining us in this talk, and finally for the organizers of the Coffee Talks for asking me to join and host this series. Thank you everyone, and we'll hope to see you in our next Coffee Talk.